Good morning. My name is Marina Castellan. I work as the neuro-oncology nurse practitioner at the Brain Cancer Group. First, I'd like to begin today's session by acknowledging our country. I would like to begin by acknowledging all traditional custodians and pay respects to elders past and present. As we endeavour to serve the health needs within the community, we recognise the importance of the land and the waterways as an integral part of people's health and well-being. The Brain Cancer Group is proud to sponsor today's education session on oligodendrogliomas. We hope you all enjoy this session and are able to learn something new, or just know that you are being supported through these groups such as the Brain Cancer Group and Brain Tumour Alliance Australia. At the Brain Cancer Group, we are focused on improving outcomes across the spectrum. We do this by taking a multidisciplinary and collaborative approach aimed at improving the lives of those impacted by brain cancer. We achieve this by fulfilling 3 tiers: research, education, and support. We welcome you to this collaborative, the Brain Cancer Group and Brain Tumour Alliance Australia Oligodendroglioma Education webinar. We now have 2 videos from our supports. The first from Dr. Raymond Cook, neurosurgeon and director at the Brain Cancer Group, and the second from Diane Dunn, secretary at Brain Tumour Alliance Australia.
Welcome everybody today coming to this meeting about oligodendroglioma. It's a meeting put on by the Brain Cancer Group, and we're in collaboration with the BTAA. Putting on as a joint exercise to encourage education about this specific subtype of glioma, this very important subtype of glioma. Thank you for your attendance. So oligodendroglioma is a particular interest of mine. It's a small group of gliomas, about 5%. But why it's so important for neurosurgeons, neuro-oncologists, radiation oncologists is that patients largely with oligodendrogliomas survive for many years, often in good physical and neurological shape. They often have many different treatments for that particular problem, often over decades. The disease was described about 100 years ago now, in the 1920s. It represents 5% of intracranial primary tumours. It has historically been described by looking at cells down a microscope and interpretation from the neuropathologist. However, just 6 years ago, it was refined by the World Health Organization, and it's now a combination of how the cells look down the microscope with the genotypical interpretation. And what that means is there's got to be certain criteria in regards to certain genetic mutations and also chromosomal aberrations to make the diagnosis. So the diagnosis has actually been quite refined just in the last 6 years, which makes it easier to interpret some of the results from treatment. Now, by and large, there's 2 types of oligodendrogliomas. There's the low grade and the high grade. The high grade is best described as a malignant tumour, and it needs treatment with surgery, radiation, and chemotherapy. The low grade is it's a pre-malignant tumour. It's a tumour that has a long-term survival, usually, and the treatment is largely surgery, which ideally is a gross total resection. However, there are other ways of managing oligodendroglioma, that's not surgical, and it's very important that the patient doesn't get or suffer a surgical deficit from an over-enthusiastic initial surgery when there are other options of treating the oligodendroglioma with radiation and perhaps chemotherapy, even in the low-grade state. The high-grade oligodendroglioma is a very interesting tumour because even though it's a malignant tumour, there can be good long-term survival with aggressive surgery, again, that doesn't injure the patient, radiation and chemotherapy. Probably the biggest controversy in the chemotherapy is what agent to use, whether to use one of the newer oral agents or whether to use some of the more traditional intravenous agents. And this is something that we should discuss. The definitive answer on that is, again, unknown. So there are some unknowns with oligodendrogliomas and there's some knowns, but overall, as I was saying in the initial presentation, it's a fascinating tumour because of the survival and the longevity of looking after these patients. Thank you.
Hello everyone, my name is Diane Dunn and I'm currently the Secretary of the Brain Tumour Alliance Australia, BTAA, and I'm living with an inoperable oligodendroglioma. I'm so excited to be part of this oligodendroglioma forum in Australia. I would like to take the opportunity to thank the Brain Cancer Group for inviting BTAA to co-sponsor this forum. I would also like to take the opportunity to thank the doctors who give of their time so generously, without whom forums such as this would not be possible. From a patient's perspective, knowledge is power. BTAA is a national brain tumour organisation. We support all Australians affected with brain tumour through our 24-hour 1800 support line, our monthly e-news, our biannual newsletter, annual forums, and we connect people to support groups throughout Australia. We are also part of the International Brain Tumour Alliance, IBTA. I really would encourage you to subscribe to our website, for you will find a wealth of information there. I do hope you enjoy the forum and find it informative. Thank you.
So just a little bit of housekeeping about today. We have 4 sessions on today. The first speaker will be Dr. Jonathan Parkinson, who's a neurosurgeon at Royal North Shore and North Shore Private, and also part of the Brain Cancer Group. We also have Dr. Michael Back and Dr. Adrian Lee. I'd just like to acknowledge the questions that were sent through initially. They really help us to direct the education session today and allow us to develop the education webinar around the needs of the patients and their carers. So these questions are really important for us, and I really encourage you to get onto the live Q&A and put your questions in there, just so that we can make sure that we're covering all areas, and it just helps us, as I said, to direct the questions to you and what you need. So we're hoping to wrap up today's education webinar at 12 o'clock and we'll get going. So first presenter, Dr. Jonathan Parkinson, neurosurgeon. Thanks, Jonathan.
Thanks, Marina. Thanks for that introduction, and thank you again to everyone who supported today, particularly obviously the Brain Cancer Group, of which I'm a board member, and also BTAA. Excuse me while I'm sharing my screen here. I hope there's no issues with that. Once again, thanks, Marina, for that introduction. My role today is as a neurosurgeon, but I'm also involved with the Brain Cancer Group and also COGNO, which is the Cooperative Trials Group for Neuro-Oncology, which is essentially Australia's clinical society for brain tumours, and it's a privilege to be on the management committee of that. And to there's no greater example, I think, in neuro-oncology of where we need to collaborate than oligodendrogliomas. A couple of key concepts to talk about before we talk about surgery, and Dr. Cook alluded to a number of these. First of all, when we think of gliomas, that are tumours that occur within the brain, there's 2 sort of real types that we see. We see ones that are localized and form like a lump, and ones that are more diffuse, where there may be a significant lump, but we know that the tumour cells extend into and throughout the brain. And that presents obviously a difficulty for us as neurosurgeons, because we can't remove brain, regardless of whether or not it contains tumour, if it's functioning. Therefore, we need to be, as Dr. Cook alluded to, very cognizant of what we might be dealing with in terms of tumours and other treatment options before we make surgical decisions. When we look at the types of gliomas that there are, as Dr. Cook again said, basically there's two sort of ways that these tumours are graded, and that comes down to looking down a microscope at these tumours, and again I'll have an example of that. But really we're looking at two sort of parallel streams, if you like. Number one is the type of cell that it looks like these tumours are. That is the sort of normal cells that the tumour cells resemble. So be them mostly astrocytes or oligodendrocytes, and thus the names of these tumours. And then down the left there, the WHO grade. So we talk about the grade of tumour being how aggressive a tumour is, how likely it is to recur, and if/when it is going to recur, how soon that's likely to be. And this was certainly the way it was from the 1920s, as Dr. Cook said, right up until about 6 years ago, when the World Health Organization, or WHO, revised their guidelines to incorporate some other measures that have become important in the diagnosis of these tumours. So now, rather than us just, the diagram's a little bit more complicated, where we're looking at, first of all, the type of tumour we think it is, but then doing a number of molecular tests. So firstly, a test called IDH. If that's what we call mutant, that is that it's abnormal. That's actually a favourable thing for tumour cells to have in terms of how likely it is for the tumour to recur and how quickly it is likely to grow. Then within the tumours that have the IDH mutation, we then further stratify these tumours based upon a test called 1p19q co-deletion. Whereas before, the oncologists used, the neuropathologists used to look at the cells and say this certain pattern of cells looks like a tumour that will behave in a certain way. Now we actually use this test to classify tumours as oligodendroglioma. So that's very important, and certainly this the evolution of this had a big influence on me as a young neurosurgeon training and choosing to get into neuro-oncology. And in fact, this is we all have those patients or those moments in our lives that certainly we feel like we shape us a lot. And this was a patient where I was on call as a fairly junior neurosurgical registrar. I got a phone call from the emergency department, and in fact, Dr. Cook was the consultant on call, and about this patient, a 34-year-old male who just had a history of headache, but it was fairly severe headache, and it was enough that that they thought he needed a CT scan. And the CT scan looked like this. There's this large lesion in the left frontal lobe. There's some contrast enhancement around the rim of the tumour, but there's also some calcification of the tumour. So again, a little bit of pattern recognition, but we could narrow this down to a couple of types of tumours based upon the CT scan. He went on and had an MRI that basically showed the same thing. And then the first, I guess, one of the most important, a few of the important surgical principles in terms of deciding what sort of surgery to do came into play before this patient went on and had surgery. So a few things: he was relatively young, therefore he was likely to be able to tolerate surgery very well. The tumour's in a location that's favourable for us to operate on. This is an area where we can remove tumours and there's usually not any neurological deficit. And then thirdly, he was well from a neurological perspective. And again, those two things go hand in hand. The location of the tumour determines what function may or may not be lost. So in this case, with this being in the frontal lobe, it's usually somewhere that we can operate on relatively safely. The left frontal lobe is the dominant hemisphere. There's some speech function contained in that for most people. However, this was still in a location that we thought it was safe. So the tumour was removed, and the histopathology at that point, this was even before we were testing for 1p19q, was that of an anaplastic oligodendroglioma. So that's really two things. We could also call that an oligodendroglioma with a WHO grade of 3. But there are a few of the features that we could see that were typical of oligodendroglioma, in particular the pattern of the blood vessels within the tumour, what we call chicken wire vasculature, and what we call perinuclear halos, which is where the way that the cells appear. but there were also some features that suggested that this was a tumour that was growing relatively quickly. And that's what we call necrosis and also microvascular proliferation. But some of those features are also seen in other tumours that are much more aggressive and have a much more significantly poor prognosis. So really, so this guy went on and had chemotherapy and radiation, and he remains disease-free 20 years after his surgery. So he was in fact the first patient at Royal North Shore that we tested for this thing called 1p19q. What this is an example of some of the testing we do. The bottom is what we call FISH analysis, which stands for fluorescence in situ hybridization, where the tumour specimen is stained in a certain way and looked at such that we can tell whether or not this genetic change is present. And therefore now it's what we need to diagnose these tumours as an oligodendroglioma. Is that important? It's really important, right? That we audited 20 years of experience with oligodendrogliomas and published this 10 years ago. And what we found is that obviously the grade's important, the WHO grade. So those tumours that were grade 2 versus those that were grade 3. Just to orientate you with this curve, this is what's called a Kaplan-Meier analysis, where this is time along the x-axis and the percentage of the patients who are surviving on the y-axis. So the fact that there's more of these patients alive as time goes on is means that there's a more positive prognosis. Then when we analysed irrespective of the grade, so whether it was grade 2 or grade 3, we found that the patients who had what we were testing for, loss of heterozygosity, but the 1p19q change at that time, that in itself was a predictor of outcome. And as you can see, this on the x-axis here, we're talking survival in years of over 10 years, irrespective of the grade. And then when we looked more closely at the anaplastic oligodendroglioma group, we found that in those patients who had loss of heterozygosity or had the 1p19q change, the median survival, that is where 50% of people were still alive, was 15 years, as opposed to those who did not have the 1p19q changes, where the average survival was only about a year or so. And that's more in keeping with what we would expect with a tumour called glioblastoma, which is a more aggressive tumour and is more of what we call an astrocytoma. So this highlights how important these pathology tests are. So for us, that really makes us have to kind of contemplate the way we do surgery beforehand, because we don't want someone who's got a tumour that's relatively slow growing having an extensive operation that may lead to a new neurological deficit. So again, we have to have this in our mind, as I was saying, the glioblastoma, like the patients who do not have 1p19q co-deletion. We didn't have the IDH mutation when we did that audit, but probably some of those patients fell into this group as opposed to those that are oligodendrogliomas. So when patient 2 comes along 10 years later, when I'm a consultant by this stage, she has this diffuse tumour, young patient, relatively well from a neurological perspective, but this is the tumour, this sort of darker area of the brain. And within it, there's some areas where the contrast is taken up, where there's contrast enhancement, and that implies that they're the more high-grade areas of tumour. It's pushing the brain right across. There's blood vessels running through it, including a very important artery called the basilar artery. The tumour extends in front of the brain stem there. So when we talk about surgery and surgery for all glioma, we talk about performing what's called a maximal safe resection. So we want to remove as much tumour as we can whilst keeping the patient in the best neurological condition they can be. And now sometimes that is what we call a gross total resection, where we remove all of the MRI abnormality. But sometimes we're a little bit more, we err more on the side of caution, removing as much tumour as we can, but keeping the patient in the best condition possible. Looking at this scan, there were a number of features that led me to believe this might be an oligodendroglioma, the patient age particularly, and and the fact that she presented with a seizure. So knowing that and knowing that possible risk, I was relatively conservative with the surgery. So what I did was remove a fair amount of the lump, but leaving some of this tumour that was going into the much more dangerous area where the blood vessels were involved, and where the brainstem is. And you can see this brainstem is still deformed there from the tumour pushing in like that. And then over to the rest of the team for chemo and radiation. This did prove to be an anaplastic oligodendroglioma. It had that IDH mutation I spoke about, and there was loss of 1p19q. So she's gone on and had radiation and chemotherapy. And as you can see, there's a bit of the white, the contrast enhancement here during the radiation in some of this residual tumour. But as time's gone on, at 6 months, then at 12 months, 2 years, and then at 3 years, you can see that that deformation that we were seeing before of the brainstem is gone. The tumour's basically melted away with the other treatment. So this is a great example of where surgery, where we err on the side of caution and keep the patient in a good neurological condition, is likely to have been to a benefit. So when we talk about surgery, what are some of the concepts? Well, it's not about getting it all out. And that's where we go back to that first slide of the localized tumour versus a diffuse tumour. I can remove all of an MRI abnormality, but I know hand on heart that that's not removing all of the tumour. There will be tumour cells beyond that, and the way to control or slow their growth is with the other treatments at the hands of people like Dr. Back and Dr. Lee. Some of the other factors in decision making, patient factors, the symptoms, the age, and their neurological function. Sorry for the error on the slide there, but also tumour location, and then some of the radiological features and how the tumours look on CT or MRI, as in the first case example. So when it comes to when we reoperate, most of those considerations still hold. Obviously their age, how well a patient is, and then of course what previous treatment they've had and what treatment they've responded to. But other tumour factors include the interval since the initial surgery, and then the pattern of recurrence, whether the tumour is, whether it's occurred within previous radiation fields, whether it could be a radiation effect, or if the tumour started to involve more of the deep structures in the brain, then perhaps we'll try further chemotherapy, or occasionally further radiation therapy in preference to further surgery. Of course, the other reason for repeat surgery is to obtain more tissue. That's something we need to do sometimes because these tumours do change or can change with time in terms of their resistance to treatment, and that can provide us with more information, getting another tumour sample either by further resection or by biopsy. So firstly, what can we achieve with surgery? Obviously, the main reason is to find out what we're dealing with, but we always go for that maximal safe resection. We make a best educated guess with the emphasis on education at the likely pathology and then tailor the surgery to that. And repeat surgery is often beneficial, particularly in oligodendroglioma as compared to other types of glioma. But this is a multidisciplinary discussion where people like Dr. Back, Dr. Lee, myself, my other neurosurgical colleagues, other colleagues in radiation oncology and medical oncology all get together and discuss things and make a decision about what we think is the best way forward. Thank you all for the privilege of presenting today. I hope that there's been some useful information there for you, and I look forward to participating in the Q&A session later on. Thanks again.
Thanks very much, Jonathan. Really important information around the neurosurgical decision making for patients, and to have those conversations with the neurosurgeon. Our next speaker is Associate Professor Michael Back. Dr. Back is the Director of the Northern Sydney Cancer Centre Radiation Oncology Department. He works at Genesis Care at North Shore as well, and is the Director at the Brain Cancer Group. Dr. Back will talk to us today about understanding imaging to predict tumour infiltration and guide interventions. Thanks, Dr. Back.
Thank you, Marina, and thank you for the opportunity with BTAA and the Brain Cancer Group to give a little bit more information about this very important type of brain tumor that we are managing on a fairly regular basis now. So today's talk is going to be a little bit of a guide as to how we utilize the information from imaging to guide the decisions, especially after that time of initial surgery, and when do adjuvant therapies such as radiation therapy and temozolomide come into play. So the management pathway that happens with patients who are being diagnosed with oligodendroglioma, often there's a new diagnosis, then the decision-making has to come in regarding radiotherapy and chemotherapy, and then eventual follow-up. The first part of this pathway after initial surgery, say from Jonathan Parkinson, is whether patients with an oligodendroglioma should have upfront treatment, or perhaps should other treatment be deferred until time of progression or changes in the medical condition. So that's the first part of the decision-making that needs to be made. Once that decision has been made, eventually if a patient then goes on to have chemotherapy and radiotherapy, then the next part of the decision-making is really based around the surveillance after treatment. And how do you interpret the imaging to pick up relapse, etc. The first part is really this concept of an observation policy. So because of the natural history of oligodendroglioma is quite slow, there is an important role to consider the use of observation versus upfront treatment. And this is a very important and very difficult part of the decision-making that happens. It's a balance between getting better tumor control immediately versus the risk of side effects that might occur. And there is no set policy for this in medicine. And the clinical trials which have been conducted regarding upfront versus delayed treatment are quite old and based upon really the era of CT scan and pretty poor quality radiotherapy without chemotherapy. So it's an important area where the imaging now has to play a role in trying to guide us as to when we come in with treatment or where we sit back and watch. And if we are watching, when do we actually then come in and deliver a therapy? After treatment, that surveillance is then looking at how well the tumor responds to treatment and diagnosing a relapse if it's occurring so that we can then consider other salvage treatments. Now, the imaging procedures we use essentially come down in 2022 to being an MRI scan or a PET scan. Now, MRI scans, everyone knows about, and your experience as a patient will be enormous with this, far greater than any clinicians will have, because you've been in that tube many times. It's quite daunting, as you can see with the image here. The patient is positioned in a head coil and then in a very confined space taken into a tunnel. The MRI scan is looking at structure in the brain and getting a correlation of that structure of anything abnormal by looking at the density of the tissue. A PET scan, however, looks at function of the brain rather than structure. So it's looking to see metabolism of the brain and where there might be different areas of metabolism. And we can utilize different radioisotopes to try to bring that out. So here's an example of the MRI scan where we're seeing quite good detail in the structure of the brain. The classical way for looking at MRI scans is we're at your feet, looking up at your head. So that's the top of the head, right side, left side. And the PET scan is showing the metabolism and comparing normal brain metabolism to where there might be a tumor and looking for asymmetry. In 2022, we can do a lot of sophisticated work with these imaging now. So they're not just a basic MRI scan. We can use it different sequences to try to work out different types of response of the brain to having a tumor in it, or to try to determine where a tumor is. And by use of mathematical calculations, we can determine different metabolic areas. Likewise, with PET scans, we can modify these to produce different isotopes, which might show up different areas of metabolism. Part of the tumor which might have low levels of, say, oxygen, and most commonly, the most common isotope is looking at low levels of sugar or higher levels of sugar. So let's concentrate on the MRI first. The MRI basically comes down to two sequences of immediate importance to look at. The first one is what we call the T2 or the T2 flare image. And that's the one localized here on the left. And that area there shows a cloud where the brain's being displaced. The other sequence is what we call the T1 sequence. And that's where we give the injection as well. And that can light up any areas which are bright, which have got a lot of blood vessels in it, and tumors or inflammation may have blood vessels, so that will light up. With the PET scan, the imaging is looking at that differentiation between the two. And it can try to map out, especially that cloud area, a bit more clearly. Because sometimes in the cloud area that we see on the MRI, such as on the left there, that area is really poorly defined. And the PET scan can then try to add more definition to it. And this is a non-standard PET scan called an FET PET scan or an amino acid PET scan, and that can help to define it. The more common type of PET scan, which happens in more clinical practice and is covered by Medicare, is the FDG PET scan, which shows areas of bright sugar uptake, which might suggest more aggressive area of tumor. So within that little diagram there with the area that's circled, that is, the whole area is tumor, but there's one area that is particularly bright, and that is suggesting that's an area of high-grade tumor within an oligo, which is essentially lower grade. So we can pick up the mix between a low-grade oligo where it might be starting to convert into a higher-grade lesion. So how do we incorporate this at time of observation policy to start off? So the observation policy, we're really looking at trying to monitor residual tumor and predict the infiltration in the brain. And so we need to look at the MRI scans in a particular way to try to answer the questions. So in this situation, the surgeon's done the operation, and for various reasons, which come down to age, absence of symptoms, patient choice, a policy is being determined to observe. Now, it means not doing nothing. So watchful waiting or observation without going to a further treatment is not doing nothing. We're actually actively watching or actively monitoring the tumor. And that means regular MRI scans and comparing regular MRI scans, especially in a sequence. So looking at sequential MRI evaluation. So here's a scan of a patient who's got quite a diffuse area of oligodendroglioma around the surgical cavity. It was elected to watch this patient. And over MRIs, we can see those areas or that cloud, that whitish space, not changing significantly. So that then suggests that we've got a tumor which is stable. But we're matching the patient on the same MRI system, and we're matching the sequences. And modern technology now allows us to do that very easily. I could do that on my iPad, you could do it on a laptop, you can do it in the clinic. The radiologist obviously can do it in their radiology suite. So the use of the imaging is really important, and comparing not just the previous MRI scan to the current MRI scan, but going back maybe 2 years to see if there's changes over time. So the observation policy after surgery, we're really trying to work out when to intervene. And the intervention comes in if patients are having symptoms. So if there's increasingly poor seizure control because of the residual tumor that's left in the brain, then that is a reason to intervene. Another reason is if the tumor is next to an eloquent area of the brain. So an eloquent area of the brain is one which has got a lot of neurological function. So areas near the motor strip, or areas near speech, or areas going towards the brainstem. They're areas which, if the tumor grows a little bit, it might start to cause significant symptoms. So we want to intervene potentially earlier. So in this image here, we've got the tumor, which is situated in the brain in this zone here. And it's right next to the motor strip, which is running immediately behind it. So the motor strip is looking after that patient's left arm, left leg. So if that tumor grows by 5 millimeters, it might start to impact that area. So that may mean a greater need for earlier treatment. The other reason why we might intervene on an observation policy is if a tumour gets new enhancement. So this is an area of a oligodendroglioma, pretty poorly defined in the left side of the brain. But on sequential MRIs, we're now seeing a small area light up bright when we give the injection. And that suggests that there's more blood vessels in that area. And that's suggesting that there may be high-grade change. This is before we've given any radiotherapy. So we haven't got that to confuse the picture. This is suggestive that there is new tumour developing and it may be of a higher grade. So that would maybe another reason to either watch more closely, do a PET scan, or intervene. The next thing is increase in size. And this is a really difficult one because if you're on an observation policy and you're watching an area of residual tumour, it will increase in size. It may increase very slowly. So it doesn't necessarily mean that the increase in size is the important thing, but the more important thing is the increase in infiltration, going into new areas of the brain, because that might suggest that this tumour is now starting to potentially act in a different way. So in this example here, we see the cavity of the surgical cavity, and around it is this poorly defined area of cloud, but that cloud's increasing and the areas of the brain there are getting thicker, and that suggests that it is new infiltration, new tumour emerging, and it's now getting significantly larger. So that might be an indication to intervene. The next area is that area of infiltration. So here's another example of tumour getting bigger over time, another example of tumour getting bigger over time. And it's now going into a slightly different area of the brain where there may be infiltration. And we know the brain's full of these roads or white matter tracts. And if the tumour starts to get into some of these white matter tracts, then there may be a pathway for further infiltration. And so it's important to recognise. So in this situation, which is marked, the oligo is extending across the midline along these white matter tracts into a new area of the brain. And that suggests that this tumour is now going into different regions and might cause new problems, and that might be an indication to treat. It also shows that these tumours don't grow as spheres, so they don't just expand uniformly. They actually infiltrate through different areas, and we've got to be aware of that. And we're going to try to predict the road or the pathway in which the tumour might be extending. And then you get dramatic examples like this, where the tumour is extending through a large amount of the brain, going down what is the representative pathways. These are two different patients, but it shows that the roads in the brain are fairly uniform, and so we can start to predict where these tumours might extend. If we see change like that, we often order a sugar PET scan to see if these changes have got high-grade change within it. And so that's why you might be then suggested to have a PET scan and one of the FTG or glucose PET scans, which can show if this tumour is low-grade and infiltrating, it might start to be changing into a higher-grade tumour on the PET. The next phase of this imaging and in monitoring patients is when it comes down to surveillance after treatment, where you're trying to assess response and you're looking to diagnose relapse. And this is difficult. Without a doubt, this is difficult. In many ways, the treatment and design of the treatment can actually be more straightforward than the monitoring of the images afterwards. Because once you give treatments such as radiotherapy and chemo after, say, surgery, you're adding potential risk for inflammatory change in the brain, which may not cause any symptoms, but the scans start to look a bit different. And so we may not be able to distinguish between what might be relapse and what might be actually just treatment effect. So here's an example of sequential MRI scan monitoring. The patient's got the surgical cavity here on the right with the tumour sitting immediately in front of it. And over time, that area has reduced in volume after radiation treatment. And the brain, which was being compressed around that area before, and the cloud looking quite diffuse, is now coming down and getting back into its normal shape. So that's a good response and correlated in this patient with good clinical outcome. So the issues we look for MRI surveillance after radiotherapy is really these factors here: tumor reduction, post-treatment gliosis or sort of scar tissue, new areas of enhancement, which might look like tumor, but might actually be treatment effect. And of course, distant infiltration and use of PET scans as well to try to determine what might be tumor or what might be treatment effect. So looking at tumor reduction first, the real pleasing thing about oligodendrogliomas in treating them with radiation therapy is that oligos tend to shrink. So the tumor's mass volume, it tends to reduce down. And that's different to patients who have got glioblastoma or what we call IDH wild type or non-mutated tumors. Those tumors tend to swell rather than shrink. And therefore you get a lot more pressure in the brain. But a patient with an oligodendroglioma after they have radiotherapy can get excellent volume reduction. So we can see on these images here, which is before radiotherapy, 3 months after radiotherapy, and 12 months after radiotherapy, the cloud area is reducing in its size and volume. And the brain is starting to regain the normal shape. And that volume reduction is happening quite early, usually at 3 months after radiotherapy or 12 months after radiotherapy. The example that Dr. Parkinson showed before, that patient actually, we repeated the MRI in the middle of radiotherapy and they already had reduction in volume. So the response to radiotherapy in oligodendrogliomas is quite unique. It does reduce down. The other IDH mutated astrocytomas also get a reduction, but the oligos tend to get that reduction earlier. And we've seen that in our own research here, where this is the reduction in the volume of the tumor for individual patients in this study. And the bluey-green color is the oligodendroglioma patients. These are patients with anaplastic oligodendroglioma. And this is the volume reduction at 12 months. And the majority of patients, the actual MRI change is reduced down by 80% in median reduction. So a majority of patients are getting good reduction of the tumor. There'll always be an MRI abnormality there after the radiotherapy is finished, but that does not suggest that there's any active tumor there. You'll be left with scar tissue, or what we call this radiotherapy gliosis. But the volume of reduction and the pressure in the brain, and therefore the potential symptoms that tumor is causing, may be alleviated by giving the treatment if you get good volume reduction. The gliosis that occurs just comes out over time. So here's a surgical cavity. You can see the sort of sharp white area around it. That's not tumor. That cloud area is just some scar tissue, what we call scar tissue, after radiotherapy and surgery. It's actually different water flow in the brain because the MRI detects water flow. And it's just that it shows there's abnormal tissue in that area. Now that can be confused with tumor, especially if it's a bit bulky. But in most cases, if it's sharp and flat and the sequential MRIs show it's not changing, especially after 2 years after the treatment, then that is more likely, most commonly, going to be this gliosis. That gliosis doesn't cause any symptoms unless it's large amounts that is producing some changes within the brain. But generally, it's just in the targeted area where we've delivered the radiotherapy. Where things get really confusing is where patients in their follow-up scans get a new area of brightness when we give the injection, or new areas of enhancement. And for some reason, patients with oligodendroglioma are more prone for this. The studies have shown, including results from our series, that in 25 to 30% of patients who are managed with radiotherapy and chemotherapy for an oligodendroglioma will get new areas of enhancement, which come and then go. They're most likely going to be asymptomatic, but you pick them up in the MRI surveillance, so it gets everyone scared because people start to think this is recurrent tumor, but it's actually not. It's actually just scar tissue after the, it's actually inflammation after the radiotherapy that can come out either immediately after the radiotherapy, or it can come out 2 years, 3 years, or even 10 years later. And we see that especially around the ventricle areas, because the cells around here may have a greater made a greater chance of getting this sort of inflammation. It can be watched, so the MRI surveillance probably increases a bit more during that time, but then over time it gradually fades away and generally does not cause any symptoms. The other part of surveillance, which is really important, is you just don't look around where the surgical cavity is in patients who have had an oligodendroglioma, because through those white matter tracts, the tumor can infiltrate further away and relapse deeper in the brain. So in this scenario here, the patient had a tumor in their frontal lobe, but the relapse has actually occurred deep in the brainstem, low down. And that's because the radiotherapy has controlled the disease up high, but the relapse ends up being distant through these pathways, well away from where we had delivered the surgery radiotherapy. And you have to watch out, not only around the surgical cavity, but also where these white matter tracts extend down to, especially in the brainstem and around what we call the fourth ventricle, the fluid space in the cerebellum behind the brainstem. That's an area where patients with oligodendroglioma do relapse, and it can cause symptoms in that area. And it's nice to pick that up before it causes symptoms and come in with second-line treatments. Finally, if there's an abnormality that's seen, then we proceed to what's called an FET PET often to try to work out whether this is actually tumor or whether it's effects of treatment. And that can help guide us. It's not 100%, and we're emerging and we're doing our own research to try to find how effective this is. But these PET scans, these amino acid PET scans can also be good for monitoring disease changes as well. So we can see in this case, the bright areas after treatment have come down. And often we see that change before we see the MRI shrinkage in some patients. More so with other types of tumors, less so with oligos, because the oligos tend to have good shrinkage early. But the PET scans can help to work alongside the MRI. And as I tell my patients and colleagues, the MRI remains king. So the most important scan is that MRI. And then the next phase of all this is if we do see changes with imaging in these areas, then that's when we incorporate the multidisciplinary team discussion. And that becomes an important part of patient care. So that's the phase of pathway of management after a patient has been operated, whether they go to an observation policy or whether you go to active treatment, and then how imaging works to monitor the progress after treatment. Thank you.
Thanks very much, Dr. Back. I think at this point, there's a question that's come in actually through the Q&A session, just asking about timing for MRI and PET scans, knowing some areas or some patients won't have access to PET scan imaging. So what are your thoughts about frequency of MRIs for oligodendroglioma patients?
Yeah, once again, that's controversial, and it does relate a lot to the access for MRIs. Generally, my thoughts are, and I guess I'm surrounded by good imaging centres who look after our patients as well. There's minimal out-of-pocket expenses, if any out-of-pocket expenses. There's a community cost because these scans are funded by Medicare. But in the first 2 years, you want to look to see if there's any significant changes. So in that first 2 years, I generally do an MRI scan every 3 or 4 months. If it's immediate treatment, then I generally do it 3 months for the first year, and then we're going out to 4 monthly in the second year. You need to look at that time course to try to pick up if there is an aberration, if this is a more active generating oligodendroglioma, or whether it's quieter acting. And the sequence of the scans doing it at 3 monthly intervals in that first 12 months will give you a bit of a clue. However, that may not be available for most people, at least in that first year, 4 monthly, and no greater than 6 monthly. If you see an abnormality, bring that forward. The issue with PET scans is different. The FDG PET scan should really just be ordered if there's initial assessment of the MRI or patient with the abnormality, and then initial assessment shows some abnormality that may suggest progressive tumor, then you can order an FDG PET scan there. The FET PET scan is more used for radiotherapy planning or to try to work out things afterwards. FDG PET scans are for assessment of diseases covered by Medicare, but the FET PET scans are not. And so they're really a research tool, but hopefully more access will be available to those as we get more data and more confirmation that this is a useful test.
Great, thanks very much. Now our next speaker is Dr. Adrian Lee, who's a medical oncologist. Dr. Lee is a medical oncologist at the Northern Sydney Cancer Centre at Royal North Shore Hospital and the Genesis Care North Shore, and also a member of the Brain Cancer Group. Dr. Lee will speak today around translating research into future targeted therapies. Thanks, Dr. Lee.
Thank you, Marina. Can everyone hear me? Thank you so much, Marina, and thank you for the opportunity and the invitation to give this talk on translating research into future targeted therapies in oligodendrogliomas. I practice at Royal North Shore Hospital, North Shore Private, and at Genesis Care. And I'm sure the audience is quite well versed in gliomas and oligodendrogliomas. So without further ado, let's get straight into it. It's hard to do any cancer talk without a flow diagram of sorts, and this one here is looking at the most up-to-date diagnostic paradigm for gliomas from the WHO classification in 2021. And of course, our focus today is on the bit I've circled in red, IDH mutant 1p19q co-deleted oligodendroglioma. As you know, this current update in 2021 has been based on a lot more utilization and integration of molecular markers into the mix beyond just the normal histological information. This is naturally a great advance in our understanding of gliomas, but it's also making it a little bit tricky sometimes to compare some of our historical data to our current molecular knowledge, as the diagnosis made back in the 1990s and early 2000s may well be different today, for better or for worse. But before we look at what the future holds, let's just recap on what is the current standard in drug treatment, I guess, for oligodendrogliomas. In grade 2 in particular, we decide on our treatment pathways based on a risk assessment, including age, greater or less than 40, the extent of surgical resection, which I'm sure Jonathan's mentioned already, and level of symptoms and deficits. In certain low-risk patients, surveillance is a legitimate pathway, and this predominantly helps to spare the younger patients from toxicities of radiation and of chemotherapy. In higher risk patients, though, radiation will probably be immediate and is followed by chemotherapy. In all circumstances, if there is a clinical trial, that would be ideal. Clinical trial in oncology is the gold standard of care in many, many ways, and it's accepted globally. Amongst a group of anaplastic oligodendrogliomas of grade 3, it's similar paradigm compared to the grade 2s, and the preferred option is still, of course, clinical trial, things like CODEL, or else immediate radiation followed by chemotherapy. In a very select group, maybe we can think about doing watchful waiting, but this is not an evidence-based practice. So in summary, the current gold standard is maximal safe resection, then radiation, then chemotherapy, with a caveat on the timing of when radiation and chemotherapy should commence, either immediately or at the time of relapse. You've probably noticed that I've been saying chemo without actually making any reference to PCB or temozolomide chemotherapy. And as most of you will know, it is a very complicated area with no clear, straightforward answer. Let us try and address this problem by going back in time a little bit. So in my timeline here, going back to the beginning, in around 1994 or 5, there were 2 trials which was started and recruited grade 3 patients, ERRTC 26951 and RTOG 9402, which I'm sure everyone's very familiar with. Both are investigating the benefit of adding chemotherapy to radiation versus radiation alone. In 1998, we did see a similar trial for grade 2 oligodendrogliomas. And it's important to note that a lot of these trials, as I said at the beginning, were reliant solely on histological diagnoses. Then in 2005, the famous Stuke protocol in GBM was published with Temodol as the chemotherapy backbone. And it's kind of subsequent to that, and I did talk to Dr. Wheeler about this yesterday as well, that there was just a sudden abrupt change to move away from PCV for no particular reason and use temozolomide instead. And so a lot of the newer brain trials have used temozolomide without actually going back to demonstrate temozolomide is better, the same, or worse than PCV. Sadly, sometimes in medical oncology, we have done things without a lot of justification. For example, say in Avastin in GBM, we've never actually done a dose finding study to recommend the current 10 milligrams per kilo dosing. It isn't even the dose we use in bowel cancer, which is 50% of that. But for some reason, when the trial started, someone decided, hey, let's double the dose and let's see if it works better in brain. And we kind of stuck with that. I've included Catnon here, which of course did not include oligodendrogliomas, but to show that in a more recent up-to-date trial, temozolomide was shown to be quite useful, especially in the adjuvant setting for radiation therapy. I know this doesn't fully explain why we've made the leap from PCV to temozolomide, but hopefully you can appreciate that there has been an abrupt change, and as a result, has posed more questions than answers so far. From Catnon and perhaps NOAA4, we recognize that temozolomide is a useful addition to radiation therapy alone. And as I keep saying, we don't know if that's equivalent to PCV, which is still seen in many parts of the world, and even in our country, as the gold standard. PCV, though, is a combination of 3 drugs, which are not easy to tolerate. Added to the fact that vincristine is an intravenous chemotherapy, it's questionable whether it actually gets into the brain in the first place. So we may well be giving a drug that doesn't do very much except to cause problems such as nerve damage in the peripheral nerves, that is. Whereas temozolomide, as we all know, is much easier to use, and let's face it, is used more widely across the spectrum, and you don't have to come into the chemo unit on a regular basis. Will we ever know the answer? Time will tell. Will we ever have the evidence to look you in the eye and say Temodol is as good, if not better, than PCV? And perhaps the answer is potentially with the CODEL study, which is also an older trial, which I did list out in the timeline, started in 2009 and is still going, amazingly. The original trial, as on the diagram here says, it's looking at radiation versus radiation plus Temodol and plus against temozolomide alone. But because of the new data that Catnon produced, the temozolomide alone arm was dropped. And in order to address this whole PCV versus temozolomide argument, adjuvant PCV was added into the radiation arm. So one can only hope with time we'll know a little bit more about PCV versus temozolomide. Let's move on from chemotherapy for a minute and look ahead into the future, or in this case, still backwards still. Because back in the early to mid 2010s, targeted therapy became a popular thing, if you like, in medical oncology. It has helped convert some of the more deadly cancers where prognosis were extremely poor in the past to having patients staying well and alive for months and months and even years. The classic examples that we see quite often are from mutation-driven lung cancers and melanoma. So as you can see, I've put in two sets of PET scan images. The panel on the left demonstrates significant bulky lymph node disease in the right shoulder region. There's also masses in the lungs, and further down into the right thigh bone here, and the left thigh bone as well. And after a period of targeted therapy, they have melted away. Similarly, in the panel on the right, again, you don't have to be a nuclear medicine physician to understand that this is lighting up like a Christmas tree. And then after a period of time, it has disappeared. In these cancers, obviously, we've seen amazing results, and apart from the radiological changes, we're seeing a lot of clinical benefits as well. And in this slide, we have a waterfall plot of a drug called ceritinib, which is an ALK inhibitor used in lung cancer. And the blue bars are all heading south, indicating the degree of reduction in the size of these tumors. And you can see that the majority of the patients had huge responses below what we deemed as a significant number, which is minus 30%. And some of them have even scored 100% reduction. Having said that, targeted therapy is not for everyone. As you can see, there's one person that didn't respond despite having that particular target mutation. And there's a couple that, was holding it steady, but didn't do enough to reduce the disease burden. So in terms of selecting targets in glioma, so is this the holy grail we've been seeking for, not just in gliomas, but in oligodendrogliomas? The interesting thing in gliomas, especially in GBM, I guess, is that from a gene and molecular change point of view, we know quite a lot about it. It's one of the first cancers to be mapped out completely with whole genome sequencing. We know everything from, all the mutations that exist. And there have been many, many clinical trials in the past 10 to 15 years to try and target these mutations. Sadly, to not a lot of success thus far. Clinical trials have not been as extensive in oligodendrogliomas, and we'll come back to the reason why, but certainly there is a bit more change in this area now, and it's particularly because of this molecule here on the right, which is IDH. And you have probably heard us talk about IDH quite a lot. We often say IDH mutation, IDH wild type, but what exactly is IDH? IDH is a very critical enzyme for normal bodily functions with a primary purpose to produce energy. How does it do this? Well, on the right is the dreaded Krebs cycle that we all had to learn as medical students, and to be honest, we probably have all forgotten. In order for glucose or sugar to be converted into actual energy or ATP in the body, the glucose goes through a range of steps that's very tightly controlled. IDH is one of those critical steps that help this conversion. In addition, it has a lot of other important homeostatic functions. Mutations, however, can occur in these areas, like in any other genes. Commonly, we see mutations occurring in IDH1, which is what we see quite a lot in gliomas. We do see sometimes in IDH2 as well, which is probably 10% of the IDH mutation. The panel on the left illustrates all the normal pathways, which again, as I said, as medical students, we remembered very well. Nowadays, not so. But what happens though is instead of the normal processes going through, on the right is demonstrating what the mutation can cause. And it primarily leads to this green chemical here, 2-hydroxyglutarate, which is a naughty enzyme or protein, which causes a lot of other cancer-related activities, which we'll come back to. So IDH was first discovered in, as I said, in whole genome sequencing in gliomas in 2008. The formation of this 2-hydroxyglutarate, which we call an oncometabolite, is quite critical and leads to multiple other changes, such as altering gene expression, allowing cancers to grow in a rather low oxygen environment. It inhibits P53, which is what we call the guardian of the genome, which allows, again, the cancer to grow unwatched. It can also cause imbalances in the energy production cycles, creating more reactive oxygen species, which causes DNA damage. It can reduce even inflammatory and immune cells coming into the tumor area. And overall, and that's why there hasn't been a lot of success perhaps with immunotherapy thus far. So given IDH is such a problem, what if we block it? Can we stop the cancer from growing? Can we cure cancer? After all, it is a very attractive drug target. It's a target, there's a mutation that influences so many other cancer-related pathways. And it's a mutation that persists. So unlike in GBM, where there's a lot of heterogeneity, where you have a ball of GBM that's say taken out by Dr. Parkinson, that corner and that corner of the GBM, and that corner and that corner may have very different molecular changes. Whereas in an IDH mutated tumor, usually the IDH persists throughout. So it's much easier to target on an ongoing basis. So what is available at the moment? So sadly, not much commercially per se. There are a couple of drugs that are being tested in clinical trials, and it's being tested in also AML, acute myeloid leukemia, and also cholangiocarcinomas. And they are a little bit ahead compared to the IDH cohort in gliomas at the moment. Most of these drugs, thankfully, are reasonably well tolerated with not a lot of significant toxicities thus far. And this one, AG881 in particular, is blocking both IDH1 and IDH2, and is meant to have better blood-brain barrier penetration. At the moment, access is predominantly through clinical trials. There is an access program through one of the drug companies, but it is quite a pricey cost, in about $20,000 a month, which leads to a phenomenon in medical oncology, which we call financial toxicity, because if it works, you kind of keep paying, which is quite a substantial amount, unless the drug company has a cap on how much you pay. It's kind of like the good old days with Avastin in GBMs, where before it was put on the PBS. Remember at that time, Roche had a $20,000 cap program, which is equivalent to 6 doses of Avastin. And unsurprisingly, the median number of doses that we tend to give was 6. Another area that's being investigated in terms of targeting IDH are vaccines. So vaccines, of course, are a hot topic in the last 2 years. And one of the many benefits of COVID vaccines are the fact that it has probably advanced this area of technology by a huge amount. And cancer, we think, is going to benefit significantly from this. And it sounds good in theory, you know, there's the IDH, what if we target this with vaccines? Vaccines in gliomas have been tried. We've had the EGFR-free trial. Unfortunately, that was negative. However, we know anecdotally that it did wipe out the population of EGFR-free cells when we've tested for it in a re-operation sample. So it wasn't so much this vaccine probably didn't work. It worked so well that it created room for all the non-B-free cells probably to prosper. Survival of the fittest also exists in the cancer world. Having said that, it also isn't so straightforward to target IDH with vaccines, because unlike, say, for example, here I've put in a picture of COVID, the spike protein is what the vaccines are aiming towards. As I mentioned to you before, IDH causes problems in the mitochondria, which is sitting deep inside the cell, next to the cell nucleus. And so whether the IDH vaccines can get into the, can cause problems for the mitochondria or deep inside the cell remains to be seen. Thinking beyond IDH inhibitors and vaccines, there are certainly quite a bit of action in many other drug development areas targeting other parts of IDH mutation and also a lot of its downstream effects. Drugs are being developed to target other molecules that arise in oligodendrogliomas or as a result of the errors made by IDH mutation and formation of 2-HG or 2-hydroxyglutarates. Other targets are also being developed to work with the IDH inhibitors that I've mentioned to capitalize on their abilities to reverse some of the cancer-related activities. The aim there is to try and reverse some of the cancer environment to make it a bit closer to normality, so that some of our usual cancer drugs might actually start working, like PARP inhibitors or immunotherapy. We've often talked about phase 1, phase 2, phase 3 clinical trials, and I thought in the remaining time period, I might spend a little bit of time going through some of the key aspects of drug developments and clinical trials. So this is a big diagram, and I've got quite a bit to say on this too. So when we hear about a drug being approved by the FDA or TGA for cancer patients, what is not often reported is the labor, time, resources that have been put in for that one drug to reach that very stage. As you can see from the left of the picture, it's a funnel effect. So we know a lot about the basic research. Like I said, we know everything about the genetic changes in GBM right now, for example. There's a lot of targets out there. So we know, for argument's sake, we know mutations in, say, gene A, B, C, D, E, F, G, H, X, Y, Z. And perhaps there are 20 companies out there that are developing drugs to target A, B, C, D, E, F, G, H, and X, Y, Z. They try this in the preclinical setting. So they do it in the little cells in a petri dish in the lab. And then if they get a bit of success, they move into animals. And it's about at this stage that you start to hear some of these prelim data coming through. And it's usually the one pager that you can Google online. Next, though, it has to be done and tested in humans, because that's what the FDA mandates in terms of good clinical trials practice and governance. The FDA rather mandates a certain amount of rigor that each new drug has to go through before it gets any approval. And as you can see in the phase 1 setting, we're looking at very small amounts of patients, usually beginning with healthy humans, because you're really just trying to see, is this drug safe to be used in human beings? More and more, because of the push in certain diseases like cancer and others as well, the phase 1 testing are being done in the actual patients with the disease themselves. What happens with phase 1 though, because the drug dose discovery stage, it means that we don't know what the right dose is to give to patients. And most of the trial structure is on utilizes what we call a 3+3 scheme. So the first 3 patients enter into the phase 1 trial at the lowest dose that deemed to be safe. And if nothing happens to those 3 patients, they continue, but the next cohort will go up on the drug level, and the next cohort will go up on the next drug level, and so on, until you hit a certain amount of drug dosing where you are experiencing a lot of toxicities. And then of course you stop. And the drug that gets taken to the next phase is actually the one down from the maximum, is the one down from the toxic dose level that was reached. And that will, as I said, that is the dosing that will be taken to phase 2. If the drug reaches phase 2, you would hope, one, that it has demonstrated some benefit to the small amount of patients so far, and that it is well tolerated. In phase 2, more patients will come into contact with the drug traditionally, and flexibility has now been given in phase 2, where there's a lot more randomized trials being undertaken. In phase 2, drugs may be pipped against a placebo or standard of care, but traditionally, FDA relies on phase 3 clinical data, where there's a lot more patients being recruited, with specifics looking at the overall survival and the progression-free survival. These are what we call the registration trials. And the problem is, as you can see with the funnel effect, not everything that gets to that phase 3 area will succeed. We've seen this quite often in GBMs. We have had tons of phase 3 clinical trials. Again, using Avastin as an example, we've had the 2 frontline Avastin trials, which were both unfortunately negative, which was caused a lot of disappointment for everyone back in 2013 or 15, and it never made the cutoffs that FDA demanded them, which was overall survival, and so it was never recognized and got registration. Why do clinical trials fail? So you say, oh, look, it's gone through phase 1, phase 2, why does it not get up when it gets to phase 3? That's a whole different talk in itself, but I will highlight perhaps the difficulties in doing trials in areas like oligodendrogliomas is the fact that it has a very long natural history. Thinking back again to the 2 seminal papers I mentioned, EORTC 26951 and RTOG 9402, the interim readings at 6 years were neutral. They couldn't find any difference. And it took another 6 years for results to actually mature and for that survival curve to actually split. And so, you know, it is a very long struggle, especially for cancers with a long natural history. So when, coming back to my original timeline now though, hopefully by targeting IDH, we can incorporate this, if it's successful in the future, to play a major role in the management of IDH mutated gliomas, including, of course, oligodendrogliomas. One would hope that in 10 years' time, we will have more data from a combination of, you know, retesting some of the older specimens and from newer trials. We will be able to develop something new that can continue to improve the survival and the quality of life of oligodendroglioma patients. That's better than our current standard at the moment. Let's hope that if I was giving this talk in 2032, I will be able to elaborate a bit more on the gold standard of maximal safe resection, then radiation, then chemotherapy, and perhaps we will be able to add in, you know, additional drugs that we can slot in at various stages to continue to delay any cancer progression into the future. Thank you very much for your attention.
Thanks very much, Adrian. I really enjoyed that talk. I'd just like to mention there that because there is talk of PCV, so the C in the PCV is CCNU, which is exactly the same as the drug lomustine. So CCNU, CNU, lomustine, all the same drug, because they do flip between those bits of terminology there. Okay. At this point, I'd just like to mention the Q&A session. If you can keep bringing your questions in, and we'll aim to answer those after the final talk. The questions are important so that we can try and help and guide this education session. Also, at the end of our webinar, there will be a survey, and if all participants could respond to the survey, it'll just help us, work out these future education sessions and direct them to where the needs are. Okay. So our final talk today is again Associate Professor Michael Back, who's a radiation oncologist at the Northern Sydney Cancer Centre and Genesis Care, and also the director of the Brain Cancer Group. And Dr. Back is going to talk about a topic that I think is really important, and something that, really amongst all the treatment that you've had is around how you continue living life after diagnosis. So Dr. Back's going to talk about dealing with the uncertainty, outcome and survivorship issues. Thanks, Dr. Back.
Great, thanks, Marina. And I promise in this presentation, I've limited to one MRI picture. So when we see our patients in the clinic and we're seeing someone who's been diagnosed with oligodendroglioma and they're coming for a consultation, they're at the age of 25, we see an oligodendroglioma as being a very optimistic thing because we're dealing with glioblastoma, a very negative prognosis most of the time. But we've still got to realize that if we're saying, well, there's a great chance that you'll be alive in 10 years' time, it only takes that 25-year-old to 35. So there is a lot of, uncertainty that happens along that pathway. Hopefully in this sort of session, I can give an idea of what's happening more recently. And I guess there's some aspects of hope to say that we're getting better survival going beyond that sort of 10, 15 years in the modern era as we're coming through. And thus we need to be concentrating on issues which are related to not only survival, but also survivorship, which is the way people live alongside of their illness. So what is survivorship? Well, survivorship can be defined as a process for living well and beyond a cancer diagnosis. And there's an increasing emphasis on health and well-being rather than only the absence of disease or illness. So that's the concept of survivorship in a nutshell. Now, from there, we can develop survivorship models. And here's a great model of survivorship that we all follow. Well, we can't because it's too complicated. But what it shows is there's multiple factors that go into survivorship. And the survivorship models have been developed for, say, cancers like breast cancer or cancers like bowel cancer, where there is high rates of cure and absence of disease progression and unlikelihood for disease progression in the years gone by. Those issues are very much different to what our patients with gliomas have to deal with in a survivorship model. So survivorship needs to be looked at in a different way in glioma compared to the usual survivorship models that happen in the community. Now, these are great. These are the templates from which we can start, but we need to develop more. Here's a more basic model, which I think is pretty good for just understanding the issues that happen alongside of one of our patients with a glioma. And so survivorship in the long-term care of the patient means managing things like complications, issues related to neurological deficits and physical function, other health issues which might come up intercurrently, social interactions, mental health, really important in terms of managing the uncertainty, and also potential loss of revenue because of the impact of the illness, loss of employment, and supports down that pathway. Relationships, and most importantly within this pathway is also the caregiver, who's a key person in our patient's diagnosed with glioma. Intermixed with that survivorship and that sort of model is also assessing what we call unmet needs. Now, sometimes unmet needs are unmeetable needs, so we can't provide an answer or can't provide a solution. But there are many needs which are unmet, which we could meet if we had better models of understanding survivorship. So here's an example from the UK, and these were patients with long-term follow-up in glioma. And the three top unmet needs were issues related to memory and concentration, fatigue, and recognizing signs of progression. So that uncertainty, how do I pick up if the tumor is coming back? And the need for support is also seen there in the same sort of features as well. So unmet needs in the survivorship model is also intimately linked, as we see in our future research. So where do we stand with oligodendroglioma in terms of survival or survivorship? So let's look at this survival issue, because I saw a lot of the questions were coming through about survival. What's the rates of survival, etc. And I think it's important to reflect upon it. Everyone's individual, so the answers that we give are based upon population data, but every person's journey along that population is an individual journey. But let's get an understanding what a survival curve is. And we use these a lot in medicine. And survival curves are basically the rate of survival here on this y-axis. So 100% survival going down to 0% survival, and the years after diagnosis. And this is the curve of which happens with the population. And the little clicks are where people are up to in their follow-up, and the steps are when people have actually died from their disease. So what we're finding is our patients with oligos, and this is our survival curve ours from IDH mutated tumors in general, is that we're getting good levels of survival going out 8 years plus down the track, but we don't have a lot of data going beyond that. Here's some long-term data from the US National Surveillance Registry. Now, the surveillance registry has got some flaws with it, but it's actually quite a good data set to sort of learn from. And this is patients with oligodendroglioma who they looked at death related to the tumor over time based upon age. And so they've got survival in months here. So you're looking about 10 years, falling around this sort of 60% figure here for various ages and lower for older age groups. Now, it's important to recognize this, that this data is actually data from 2000 to 218. It's good numbers, but a lot of things have changed in that time period. And I use a pretty rough analogy sometimes. It's like the iPhone. So you wouldn't make a phone call now with an iPhone first generation. You could still probably make the phone call, but you could do things a hell of a lot better, a hell of a lot more efficiently, and have better results if you're using a later generation. Same things if improvements in time in this sort of technology is also improved in technology when we look at brain scans. And so this is an MRI back in 2012, and this is the same patient's MRI scan in 2020. It's the same patient, it's the same MRI provider, it's just better software and better equipment on the machine means we can see a lot more detail in the brain compared to what we could in the past. And as a result, we can manage people better if we can see more things. So if a surgeon can see more things day one, they can make an appropriate decision regarding surgery. If a radiation oncologist can see things more day one, then we can make a much more appropriate decision in regarding the design of treatment. So there's been improvements over time. And what we're seeing is if you look at data sets, say from this US SEER database, where we're looking at patients from 2000 onwards, then if we look at more modern data in shorter subsets, we're seeing these curves lift up. So these curves will lift up and they will get better survival at later times. And we're seeing this from those clinical trials that Dr. Lee showed before. The results seen in those trials compared to our current data sets are a lot better. Now, this is unpublished data, but data from our own patients who have been managed with newly diagnosed grade 3 or anaplastic oligodendrogliomas. These are patients who we see upfront and we deliver treatment. And this is our North Shore data over with a good subset of patients. And our overall survival at that sort of 12-year mark is in the order of 85 to 90%. So that suggests that at, going down in the future, we're seeing about 10%, 15% of people dying within 10 years after diagnosis, but the majority of patients are alive, and greater than 80 to 85% are alive 10 years plus down the track. And that should convert to better 15-year survivals and hopefully better 20-year survivals. It's very hard to judge 20-year survivals because you need 20 years of good MRIs, and we don't have that. We actually didn't have MRI. I wasn't allowed to prescribe and order an MRI to an outpatient when I started as a specialist in '96. So it's only in recent times that we've actually had really good access to MRIs and really good access to really good quality MRIs. The other thing about these survival curves, that's the overall survival in our patients. There's also relapse-free survival, once again, our data here. So in that first 10 years, we're seeing a number of patients who have relapsed, but they're still alive. So we're also seeing patients who at 10 years, a majority of patients, have not relapsed or are projected not to relapse based upon these survival curves. These survival curves are not published at the moment because we need more time for them to mature to be relevant. But the data is tracking well to suggest that in patients managed from 2008, 2010, 2012, 2016, we're seeing better survivals. And we're seeing that in our patients with glioblastoma as well. So we've looked at our own data and patients treated before 2013 versus patients treated after 2013. The patients after 2013 are doing better in terms of survival, even though it's the same recipe in terms of radiotherapy and chemotherapy, because a whole lot of other factors, support, imaging, the way we deliver the actual treatment has all improved. So we're actually getting better outcomes. So thus the future emphasis should be more on survivorship rather than the actual survival, because we've got to make sure that we're looking after our patients. So here is a very brief 10 research lessons on survivorship in patients with oligodendrogliomas or favorable subtype brain tumors. This is mixed with a bit of dogma as well, so I apologize for that, but there is limited data coming through, but the data coming through is very interesting. So we've published our own patient cohort of patients with RDH mutated tumors or favorable subtype tumors, which include the oligodendrogliomas, and looking at patients who are 5 years plus down the track after initial diagnosis. And what we found is that survivors have good function, but there may be some deficits and impact. So if we look at our patients 5 years down the track, we're seeing that the patients have what we call ECOG 0 or 1 performance status in more than 90% of patients. So they're managing well, they're functioning well. We're also seeing that patients returning to employment after completion of radiotherapy for these favorable subtype tumors, in the patients who have got the follow-up beyond 5 years, we're seeing high levels of patients returning back to work. But if we go back to the start, we're seeing before the radiotherapy, a whole lot of patients who are impaired at baseline who couldn't work because of the nature of the tumor or the nature of the effect of the subsequent initial treatments that were required. This is really good data from University of Melbourne with Kate Drummond's team down in Melbourne, who are projecting patients and doing follow-up on patients who have had initial operation for a favorable risk glioma. And they're finding also that patients can have good function, but there are deficits and impact which happen at time of initial diagnosis. So their curves here show a rate of quality of life of various domains and various scores, with the grey being the normal population and the black areas being the low-grade glioma population. So we're seeing that groups of patients with low-grade gliomas have got lower quality of life in various domains compared to a normal population in the community. So it's important to recognise there are deficits, even though our patients do have relatively good function. This is interesting data that's not published yet, but presented, and this was presented last year. And this is from the Dutch, who have done a lot of good work in quality of life and neurocognitive function after glioma treatment. And they've published on following up their patients with low-grade glioma 26 years after diagnosis. So firstly, we've got patients alive 26 years down the track, which is fantastic. And they're actually looking at those patients and doing audits on those patients over time and looking at their health-related quality of life. And what they're saying is that the patients actually maintain their function pretty well over time. So if you get through the initial insult okay, then your general quality of life is maintained down the track, even at time periods 26 years after initial diagnosis. Next research lesson is relapse of tumor is obviously bad. Now we don't need, we just look at that one MRI and we can see the full extent of infiltration in the brain, and that's obviously going to have an impact on the patient. So relapse of tumor is obviously bad. So therefore we have to make our judgments as well as to when we time in for treatments. So even though a treatment might have some morbidity, we don't want to let the tumor progression through delaying it lead to greater impact. So it's that initial decision-making around observation and when to intervene becomes really important. Also, multiple craniotomies is also probably bad. Now, this data is not strong. Our data was suggesting that as well. The patients who have multiple craniotomies, and by default, that generally means multiple relapses before they come and have treatment, have potential issues with quality of life or other neurological deficits. That's controversial at the moment, but there's data coming through. This data here is actually from the UK, and it's actually in meningioma patients. Our data in gliomas has also been published, and that did suggest multiple craniotomies did have an adverse effect on some of the functional issues, returning back to work, etc. But it probably correlates with relapse of tumor, not just a surgical procedure. Lesson number 5 is that seizure medications need to be optimized. So we think about late side effects from the radiotherapy and the chemo, but the anticonvulsant medications also potentially have an impact. And they can have other effects on the body and other effects in terms of patient functioning. And sometimes cognitive issues, etc., may need to be addressed. And sometimes it involves a need to rotate the anticonvulsant medication. Some patients need to stay on anti-seizure medication, but other patients may need to actually have their medications optimized and maybe rotated to try to minimize the effects that might be evident from one drug over another. That's a very difficult and very specialized area as well. Next research lesson, what we're learning is that radiation therapy design is probably more important than the machine. So this is an example of a patient treated elsewhere and a patient treated by myself in a sort of a sophisticated brain tumor practice. Now, rather than using basic field arrangements and design of treatment, we use multiple beams to try to minimize the dose to the normal brain. So the machine is actually the same. It's the same machine. It's got the same hardware on it. It's got the same software on it, but we can utilize the design of treatment on that machine optimally if we've got a good pathway set up. So there's a question, I think, about proton therapy. Proton therapy is a good machine, and there's going to be a proton therapy machine in Australia in the next couple of years, which would be great down in Adelaide. However, it's not so much the machine that's important, it's how the treatment's designed on it. And most of the machines now mimic some of the dose characteristics that protons can give. And in fact, in Europe, there's various centers who won't treat their glioma patients on protons because it's actually not favorable to actually deliver treatment in that way for a brain tumor, where you need a graduated dose rather than a very sharp area of the dose. It's a technical issue, but it's actually not the machine that's important. It's actually how it's designed, which is bringing out more information. And we see that in some data coming through now. And this is the data from India, actually, where they looked at young patients with low-grade brain tumors, and they looked at patients who were treated in a standard manner versus treated in a sophisticated manner, and they saw better quality of life and cognitive endpoints at 5 years plus down the track for more sophisticated treatment. But there's not a lot of data on that to quote. Research level lesson number 7 is that we've got to accept the quality of life at 3 months after radiotherapy will be lower, but then it improves. And this is data from a low-grade glioma study that we're involved with at North Shore. It's a European study. And they looked at the quality of life points after radiotherapy. And in the 3 months afterwards, people had more fatigue, etc., but it came back to where they were at baseline. So there is an improvement over time. Now, big issue here is fatigue and depression are intimately linked, and they appear to be important symptoms. So in that Dutch study looking at 26 years down the track of follow-up on patients, fatigue and depression were the two big ones they looked at. And fatigue, depression, and cognitive function are intimately linked. So if you're tired, your cognitive function's off. If you're not managing well with your tiredness, that might lead to depressive symptoms. So they're all interrelated. And patients who come into the clinic with excessive fatigue, you got to think about cognitive function, and you also got to think about depression. So in survivorship, you have to look at all these factors merging together. And this is also data which we're seeing in Kate Drummond's University of Melbourne study as well, is that cognitive changes, they're influenced by multiple factors, but mostly the initial site and extent of the tumour. So what their study shows that this is curves of patients who have had normal population. They put a point where there was potential clinical relevance if your cognitive function is lower than that point. And they found in their groups of patients that there was a lower cognitive function in their patients in follow-up, but it was all based around where they started off. So if we can get through and support people to that initial part, then and minimize the effects of the diagnosis, effects of the operation, effects of immediate treatments and seizure medications, etc., we can potentially stabilize people's cognitive function, hopefully improve it, or start them off at a better time point. But sometimes the tumor is there that's caused the issues, and therefore the cognitive function is hard to reverse over time. The other aspect is behavioral change, including exercise and mindfulness meditation practice, may have an impact on well-being, and thus cognition and lethargy. So if you think that cognition, lethargy, and depression are all merged into one, then wellness practices and getting people in a survivorship program to be concentrating on wellness, which might be exercise or meditation, that may impact on lethargy, which might impact on cognition and might impact on depression. So all these things are intimately linked, but we need more evidence. So we need more evidence, and the best way to get around that is to design a structured approach to survivorship. We need a structured approach. We need to look at assessing patients' unmet needs, and then we need to develop a wellness plan. And this is the basic model that comes out from the oncological societies in Australia for all sorts of cancer subgroups. And then the most important feature of their plan is self-management, where the patient is the person driving their survivorship model. Now that may be okay with breast cancer, but not in our patients who might have some cognitive issues. So for brain tumors, we actually need a different approach. We just can't rely on the basic survivorship models which have been developed and some basic survivorship patterns, because self-management, if you've got cognitive issues, if you've got other issues, may be difficult to drive. So we need to get a reboot in the model. So let's look at the Australian programs that are available for survivorship. And unfortunately, the screen is blank because we actually don't have any, apart from some small institution programs. We don't have a coordinated approach to survivorship in Australia for our patients with oligodendroglioma or favorable risk brain tumors. There's an absence of programs. We don't have any structure to develop. So instead of Australian programs, we've got to look at Australian research. And this is where we need people associated with BTAA to be really actively involved. So the University of Sydney has got a big Cancer Australia grant called the BRAINS program, which is looking at brain cancer, rehabilitation, assessment, and innovation for survivorship needs. Now, the first thing is we've got to differentiate patients who have got oligodendroglioma or low-grade tumors, favorable subtype tumors versus glioblastoma. They are two completely different illnesses. So we have to look at patients who have got glioblastoma and say brain metastases and look at them differently compared to patients who have got RDH mutated tumors or oligodendrogliomas and meningiomas. And we look at those patients in a different cohort because the two models are completely different. The two needs are completely different. We're talking more emphasis on survival for the bad type tumors, whereas in the oligos, etc., we're looking at more long-term survival and survivorship needs. So we really do need to separate the two. And we need BTAA supporters to be right behind this. So if there's surveys being done or research being done, we want people putting their hand up for the BRAINS program. That's a really important one, and it's been running for about 18 months now. So we should be getting some data coming through from the Big Cancer Australia grant. Likewise, we need to look at studies like the University of Melbourne, Kate Drummond's one, which is looking at the quality of life after surgery for low-grade glioma. And the Brain Cancer Group is also doing a functional survivorship audit, but this time at 5 years after radiotherapy, and looking at correlations with MRI changes in our patients that we've managed. So we're looking at those different areas of research, and the aim would then be to develop a survivorship program which can run across Australia, not just in Royal Melbourne Hospital or Royal North Shore Hospital, but it can run as an Australian-wide thing. The other thing which is important to recognise is that this is not for doctors. It's not for oncologists. We need to be aware of what's going on, but we need this to be driven by our psychologists, our occupational therapists, our physiotherapists, our support nurses and nurse practitioners, etc. The doctors are concentrating on different things and unfortunately do neglect different things. But we actually need to get the community health driving in with the general practitioners and driving with community supports to develop these survivorship models. And the BTAA is really well situated to be a key driver for that, working with these units. So thank you. That's a bit of research and a little bit of dogma, but hopefully that will raise some further discussion. Thank you.
Thanks very much, Dr. Back. So that's the end of the talks that we have today. Again, it'd be great if you could keep popping up the questions in the live chat. We'll try and answer what we can. I think a lot of the questions that have come up initially prior to the webinar today and during the webinar hopefully have been answered for you. We also encourage you at the end of the session to complete the survey for us, because that will just help us direct and guide how we do these webinars in the future and what you actually want from us and what things you need. So now we're just going to go on for the next 15 minutes and try and answer some of the questions. I will go straight into the survivorship sort of stuff since we've just had that discussion, and look at some of the survivorship questions. If the doctors can also just have a read of things as they're going on along, and if there's other things that they can answer at the time, that would be great. I'll jump straight into the diet question because we see this one quite a lot. Any particular diet, vegetarian, keto diet, any sort of diet, you know, there's a lot of discussion around reducing sugars. So what are the recommendations? I suppose, what is the data?
I'll just jump in there. The data is pretty minimal for our patients with brain tumours. There's no strong data to suggest a particular diet is good over another. I generally say the bottom line is what's good for your heart will be good for your brain and be good for controlling your body's immune response to control the tumour. So if you're having things which are good for your heart, and there's various basic heart models out there which are fairly common sense, then that will be the better model. Balanced diet rather than any extreme diet.
Yeah. I think the Mediterranean diet and those things that are good for your heart are the ones to go for. Again, about any data to increase quality of life and things that we've so far shown, and I think the exercise programs and the data around fatigue reduction with improved quality of life with exercise. So Dr. Back, can you talk a little bit about that again, please?
Yeah, so a lot of the data for exercise is based on other cancers in terms of dealing with fatigue rather than patients with brain tumours. Obviously, some patients with brain tumours have not got that ability to exercise in a standard way if there's a neurological deficit, but pleasingly, most of the patients with our oligodendrogliomas that are shown in our long-term data have actually got high performance status. So they should be able to partake in an exercise program. And that exercise program can just be basic things that we'll be recommending to the normal population anyway. It's nothing extreme. It's just keeping activity levels up, brisk walking, that gets heart rate up to a certain level, and then looking after diet associated with that. There's no particular exercise regimen, but if people are unable to exercise because of neurological deficits or for other reasons, then an exercise physiologist could potentially guide their care.
Yeah, great. So further on to that, just opinions about return to work and continuing to work. I think having purposeful, meaning in your life, a big part of our lives is work and what we do. So when you've been diagnosed with an oligodendroglioma, how do you fit the work, and is it okay and good for you to continue working if you're able?
Yeah, I'll go for that again. Yeah, look, we encourage people to maintain their work. This is a long-term chronic illness, and there's not an illness involving the organs. We make you temporarily tired and lethargic through radiation and chemo, but you recover from that. So if you've managed okay through your initial diagnosis and the impact of the tumor and the impact of the surgery, we don't forsake people's occupation. Even our patients with a glioblastoma, if they get through their operation okay, 20% are working during their radiotherapy. Working provides a purpose, it provides a social interaction, and obviously it provides revenue, which is important. So we encourage people to maintain their working, but obviously they can have periods of time off working as required, and we try to facilitate that. Also talking to your employer about what your roles are and the need for having some time off if you've got lethargy is a much more better approach than actually just stopping work completely.
Yeah. All right, I'm going to jump off to another subject and leave you alone for a little while, Dr. Back. There's been a lot of discussion around, inoperable or unresectable lesions and the proportion of these. I'm not sure that the right wording is inoperable, but, Jonathan, can you talk a little bit around inoperable, unresectable, and safe resection, please?
Yeah, I think that's a great question, and it's a very difficult thing. In some respects, all tumours are inoperable because the tumours always, these diffuse gliomas extend into brain that's functioning normally. So, whereas in, say, the bowel or something like that, you can take a very wide margin of tissue, like a normally functioning tissue with a tumour, you can't do that in the brain. So fundamentally, that's why we always take a step back from using terms like operable or inoperable as surgeons, because we know that in many respects all tumours are inoperable. So then it becomes, what's the most we can do without causing any harm? And I think the second case I showed was a really good demonstration of that, where I worked out what I thought I could do without causing any problem, and that helped remove tumor bulk, so there's not a bigger area of the brain that ends up, or bigger area of tumor that has radiation that can swell and all those sorts of things. So that's one of the reasons why there's a benefit in doing a sort of maximal resection, but left part of it knowing that if I push things too far, there's a high chance of a stroke or other sorts of complications. So I don't think any tumour is truly inoperable. There's always something we can do. Sometimes it is just a biopsy, which can be done via a needle rather than by a craniotomy. So, but again, it's just a matter of discretion being the better part of valor, I guess.
Yeah. And I think also there was a question around, even if you do a biopsy, are we able to test for the 1p19q and IDH? And the answer to that now is yes. So, and we've had cases from, many years ago at North Shore, we do have a brain bank, and where we've been able to retrospectively test things. So, yeah, where in the past we, didn't have that IDH, we've been able to go back and retrospectively look at that. So, yes, we can do testing further to that now. Okay, just around also the grade 2 and grade 3 oligodendrogliomas, there are a few questions around the lifespan, I suppose, of somebody with a grade 2 and time to recurrence. Is there any data around that, or?
Yeah, you can speak to that, Michael. Yeah.
Yeah.
I was just going to refer to our data. But...
Yeah, I guess the grade 2 data, you have to look at that in the concept that sometimes the biopsy is just sampling a certain area of the tumor, and then within it's got grade 3 tumor within it. And more, we're looking at these types of tumors now as being what we call lower grade gliomas, and that the 2s and 3s are being managed in an equivalent way. So the concept is that if you go back right to the 1990s, there was an upfront versus delayed study for radiotherapy in low-grade gliomas, so grade 2 gliomas, and the median time to progression, the time to relapse, was about 3 years in the patients who were observed. So there is that. That's about as good as data as we get, because the rest of the patients are sort of more mixed. But now, if we're looking at patients now in 2022, we're looking at patients being a mixture of both grade 2 and 3 and mesoderm under one policy. If there's been a complete surgical resection and there's no gross residual disease behind, which is an unusual situation in most patients with oligos, because a lot of our patients do have some residual tumor behind, then perhaps you can look at that saying, if just purely grade 2, we've got a good sample, then that patient can have maybe a different prognosis. But generally, in our grade 3 patients, we're seeing this 10-year survival of exceeding 85%. So we're presuming our grade 2 patients are in that same zone as well.
Okay. And I think we've spoken a lot about this, but it is, that timing of radiation, as I think Adrian brought up, if you've got a grade 3 and you're greater than 40 years of age, you should opt for treatment straight away. So just around that timing of radiation and chemotherapy, and where do we use watch and wait or surveillance scans for these patients? Michael?
Adrian, do you want to?
Sure. Yeah, I can start first. I guess ultimately, the radiation and chemo, we now know, goes hand in hand. So I think if radiation was to start, chemo will have to go along with it. So the big question is, do we start radiation at all? And if there are nasty features, then I think the answer is yes. And as Michael said, the way we treat grade 2 and 3, which I probably should have highlighted, is probably quite similar nowadays. And it's going to be looking at your age, the level of resection, and any deficits thereafter. And obviously, if you're 20 and getting diagnosed with grade 2, there might be more talk or focus about, do we spare the patient from the effects of radiation and chemotherapy because they are younger, or compared to someone who's, over 40. So I think that's kind of, and it relies a lot on the MDT discussion with Michael, radiation oncology, with Jonathan and the surgeons, and us, and us med-oncs in the room.
Okay, so while we stay on that, you answered a lot of the questions around clinical trials specifically for oligodendroglioma patients, those being CODEL and the IDH inhibitors. That was a great talk. I enjoyed that. So I think we've covered off those questions there. There was a question around the Optune cap. Dr. Lee, if you'd like to cover that one off. We've seen this more so, I think, in the high-grade glioma patients.
Yeah, correct. I don't think we've had any on for oligos using the caps. And again, this is something that I actually talked about with Helen yesterday as well. I think we've only had 2 in the campus. I remember seeing one as a trainee registrar, and there was another one that came through. The caps logistics is probably one of the issue. It's available in Singapore. In the past, it was available in Switzerland. I think our patient had to go to Switzerland to get the cap. And you wear it quite a long time during the day. And so, in Australia, it's a bit of a hotter environment that makes life a little bit more tricky. The trial data did say that it was positive, but I think, if it was such a good thing, I think everyone would be doing it, and the cost would be reduced, because that is also quite burdensome, that cost of getting the cap in the first place. So I guess the direct answer is we're not using it for oligos, and while the data is there for GBMs, it's not commonplace either.
It's a bit cost inhibitive, isn't it?
Yeah, I'll just touch on that as well. There's no data for oligos because the time course for wearing it's continual wearing. For glioblastoma, it's really interesting. I mean, as a physical therapy, this is electromagnetic radiation going across the brain, and it needs a lot of supportive care. So one of the questions about the clinical trials is that could this just be because patients are getting better supportive care? Are the carers getting better advice? Because a nurse has to see them every week to sort of reposition the electrodes, etc. So are we seeing more directed supportive care in this group of patients? That's why the clinical trial is positive in glioblastoma. However, in the last, or coming out very soon, is a publication looking at the patterns of relapse of patients with glioblastoma who had Optune, and it looks a little bit different to what we would have expected. So maybe there is something there biologically, but it's got a lot of prohibitive features for it. We've still got to learn a lot about it. And the prohibitive features are not just cost, which is quoted about $20,000 a month, getting it from overseas, but also the supportive care. There's no program in Australia. There was an attempt to try and get it in Australia, but it was unsuccessful, both in terms of the provider and also the ability to provide the service. It's an interesting concept, but not for our patients with oligodendroglioma.
Thanks very much. We've only got a couple of minutes left. Just to remind you of the survey that will come out, if the attendees could please complete that survey and get back to us. You can also find a lot more information on our websites, the Brain Cancer Group, www.braincancergroup.com.au, and also Brain Tumour Alliance Australia. Their support of patients is outstanding. Again, www.btaa.org.au. This webinar session will be recorded and will come up online for you to watch at a later date, because I think sometimes you tune in and out of conversation, so it's a good one to re-watch. One final thing that I will ask is around return to driving. How do patients, this is a big one for patients, obviously, also around the return to work relationships, from a supportive care sort of thing, return to driving in this patient group, especially if around seizures, is a big one. Dr. Back, you always fill out the forms.
It's a controversial one, but essentially from our long-term follow-up, patients with favourable risk gliomas and oligodendrogliomas, if they're not having seizure events, do return back to driving. So we're very positive in that. The issues for return back to driving, what are prohibitive? Generally in the 3 months after an operation, it's actually a surgeon's discretion time point, but roughly 3 months after the operation, you can return back to driving if there's no other issues. If you had one seizure, you can't drive for 6 months. If you have multiple seizures, you're barred for 12 months. And so you need to be seizure-free for 12 months. If you've got a tumour which is present in the brain but is stable, then you can return back to driving. If you've got progressive tumour or bad inflammation, you should not be driving. You should have a temporary halt to your driving. If you've got bad neurocognitive function that affects insight and decision-making, that's the terms in the RTA, then you shouldn't drive and probably should have an occupational therapy assessment as to your ability to drive. The major barrier is if people have still got a bit of swelling after treatment, then that we just hold back their driving until the MRI stabilizes. Anyone who's had a brain tumour will have a conditional license from the RMS, which means that your conditional license means you're subject to periodic medical review. And for that reason, the MRIs are important because they're part of that periodic medical review. So the consultation says you're looking well and you haven't had a seizure, but the MRI is also important for people who are driving for long-term follow-up and long-term safety, that there's no new progression. So they're the sort of factors we take into it. You can be Matt Verstappen, but if you've had a seizure or a craniotomy, you're not allowed to drive on a New South Wales road for 3 months or 6 months. So you can be an excellent driver, but you've got to be able to have those criteria to have your license. You don't lose your license is temporarily suspended and it converts into a conditional license based upon periodic medical review.
Excellent. And I think we'll finish the webinar there. We've hit just over 12 o'clock. Thank you all for a very, very good session. Even though I work with you all, I learnt a lot. Great talks from everybody. Again, just to the audience, if you can help us complete the survey that will come out to you, it'll just help us with future events. Thanks very much. Bye-bye.
Bye.
Thank you all very much.